Hello, good afternoon. My name is Chang. I'm the Associate Director of Cardiovascular CT Lab here at Methodist Hospital. Today I'm going to talk about a little bit basic principle for cardiac CT. So this is a timeline for those who are not familiar with the development of cardiac CT. You can see that the technology has evolved drastically over the last 20 years, and so most of the scanner that we use has at least 64 slices, and the newer one has up to 250 slices, and some of them have 2 detectors, and now we have the newest spectral or photon counting CT that's really pushed the capacity of cardiac CT in detecting cardiovascular disease, not only coronary. Okay, so what's a CT? I mean, essentially CT scanner is a motorized X-ray source that rotates around the patient and called gantry, so using a called gantry. And then the other side of the X-ray source, there are detectors that capture the photon after the electrons go through the patient. Okay, so you could have single source of X-ray or 2 sources of X-ray. Okay, and the patient go in the middle. So noted that X-ray source and detectors only rotate through the hole. Patient is the one that goes through that gantry to be images. Okay, so what are the process? The basic process is we have to acquire the images first. So again, I'll show you here X-ray tube, apply current and the potential. That's how you can program that in your scanner and rotate around the patient, and the detector capture the images. And then using mathematical model, you convert the transmission images into the image display that we used to see in our workstation. That's a very simple description. Obviously, the process is very complicated and very mathematically involved. So why is this important? Why do we care about, this X-ray source? Because we will learn later this will affect the image quality. So essentially, this is how we generate electrons by heating up cathodes, and then the heat generate electrons, go from X-ray source, go through the patient. The electron either get absorbed, go through the body, or get scattered. So, and you catch it on the other side with the detectors. Okay? That's a really basic principle. All right, so after the detector capture electrons in the form of photon, using, again, mathematical model, we convert those into each ray have converted into a transmission images, and then for cardiac study, usually generate about 250 or even thousands of images. 250 actual images, but that involve 100,000 of transmission measurement. So it's a very data-heavy process. So why is the X-ray tube current important? So the amount of energy we apply to that X-ray source that I showed you earlier will create a certain amount of radiation, the number of the number of X-ray photons is equal to intensity, meaning that more MA, more photon, more radiation, okay? And then the amount the patient receives it's determined by the tube current multiplied by the time. So you can see here, in these images here, so this is a patient who had a study done in image was acquired throughout the cardiac cycle. You can see at the beginning is very blurry. Okay, it's called dose modulation. So in the beginning of the cardiac cycle, we apply very little MA, so you can see that it's very grainy, right? So, for instance, here, this is a patient who received lower MA compared to higher MA. Better contrast, better image quality, but higher radiation. So, have that in mind. All right, and this is why it's important. You know, we have a lot of patients with a lot of soft tissue attenuation, meaning that all the electrons generated by X-ray, if you don't give enough, most of them will be stopped at the tissue level, and none of them will get to the detector. If you don't get to the detector, you don't have signal, you don't have pictures, okay? So the rule of thumb here, obviously, this is very approximate. But if you give twice of MA, you increase the signal noise ratio by about 40%. But this is most of the time you don't really determine that. I mean, the machine directly calculate the attenuation and determine the MA. So, but sometimes if you're a big patient, you can adjust. You can increase it up to, you know, sometime 100 MA, 1,000 MA. Okay, this is another example, lower MA versus higher MA. Again, you can see the difference, less noisy. Okay, KV. Okay, so I want to differentiate two concepts. KV is the maximum voltage that you apply across the cathodes and anodes that I showed you earlier. Okay, and that is determine the energy, the electron travel. Okay, so the KV is the voltage across the X-ray lamp that generate. So when you apply a KV, that's why you generate what we call KEV, okay, which is the spectrum or wavelength X-ray energy for the main beam. And this comes in important to talk about photon counting CT later. Because X-ray, when you apply a KV through the source, you generate different energy. So some of the energy are not useful. All right. So what happens when you have lower KV? Okay, lower KV meaning that a lot of electron get stopped because there's less energy. Sometimes cannot penetrate the tissue. So if you have that, you're going to have more noise. Okay, just like here, you have more contrast. It's brighter, but you don't see as well the border between tissue of different Hounsfield unit, okay? So this is the same patient image in 120 kV versus 110 kV. I mean, there's subtle differences, but you can tell the contrast signal is a little brighter because 100 kV is close to the iodine edge, so you get more iodine signal, but you can see, I mean, the resolution is not as good, okay? Especially with tissue of higher density, because the energy is not high enough to go through those high attenuation objects. Okay. So what's the implication, okay? So if your tube current is directly proportional to the amount of radiation. So if you increase by 20% in the tube current, you increase the radiation by 20%. But from the voltage, is is not linear. So if you increase from 100 kV to 120 kV, you increase the radiation by 40 to 44%. So have that in mind. Okay, so we talk about the MA and the kV. Let's talk about what actually do we see, okay? So basically you apply X-ray through the objects, see it will be the body or the heart, and depending on the composition of the tissue that you image, you're gonna have different attenuation. So you have a attenuation profile, and remember the reconstruction process that we mentioned earlier give you the image that we see. And water, by convention, will be zero. Basically means that anything dense, not less dense than water, would be negative, such as fat or air, okay? Anything denser than water will be more positive. And we do this all the time. And that's why actually CT can do some tissue characterization, but in the extreme, meaning air versus metallic or bone structure, right? Anything in between the soft tissue is not that good. And that's the main reason why we give contrast. So we can separate the vessel lumen with the tissue around it. Because the blood is about 40 to 60, and the tissue around the lumen is a little bit higher. So imagine if we can give contrast into the lumen, make it about 300. Now you can tell the border between the lumen and the tissue. And that's why the reason why we give iodinated contrast, okay? But not everything, again, this is just an example. You can sample all the tissue and give you the Hounsfield unit. And I think the most useful for this is in assessment of pericardium, right? I mean, sometimes you see pericardium, you don't know, is it fat, is it fluid, is it thickening, so you can see here, I can tell this is calcium, there's no question, patient with pericarditis. This patient, this Hounsfield unit is 110, so this is not fluid. This is very thickened, inflamed pericardium, soft tissue. You know, if you don't measure it, you might think, oh, this is just a little bit of pericardial effusion, but this is not. And patient also had MRI showing that. So this is a fluid, and this is fatty infiltration, okay? So that's how, again, this is same here. We have calcium in the myocardium, so you can tell, you know, you have hypoperfusion. Again, but for calcium and fat, you don't need contrast. But if you want to differentiate soft tissue, you need to give contrast, okay? So that we talk about is very specific for air, water, fat, and calcification, not for soft tissue. You might say, how come air is important for coronary? Well, I mean, sometimes you want to make sure there's no air in the cardiac chamber when you inject the contrast, because sometimes you don't want to incorporate bubbles. And so, but it's very easily seen. Okay, so how good is the spatial resolution of CT? So this is kind of essentially tell you what spatial resolution is. So if this is almost, remember, imagine this is two vessels side by side. If your detector that determines spatial resolution is very big, you won't be able to tell these two are actually different. So if your image, it looks like one elongated structure versus if you have, 50% smaller detector, you can actually tell this difference apart. So this is not that different from other imaging modality, okay? So the spatial resolution, remember you have what we call in plane. So when you do the axial view, X and Y axis, usually it's determined by geometric characteristics of the scanner, and Most of them has it between 0.4 to 0.5. That's why the holy grail of everyone working on thin slice is to achieve similar spatial resolution in the through plane, meaning z-axis or cranial-caudal axis. Okay, so invasive angiogram has the spatial resolution is 0.1 millimeter. Currently, most of the scanner has 0.6, 0.5 millimeter. With the new photon counting CT, it goes down to at least 0.2. So we're getting close to the invasive angiogram, but not quite yet. So the spatial resolution of most of the scanners determine how thin the collimation is, okay? How thin the slide. As you can see, there's the same manufacturer limit to how thin the detector could be. Also, when you have very thin detector, it doesn't get much signal input, so you will be very thin, therefore it's going to be noisy. So, and you need to give higher energy to get more signal. So actually, when you went from 16 slice CT to 64 slice CT, if you want to produce similar images with the same noise signal ratio, you have to actually increase the radiation dose. Okay, so this is very important. Some people think 64 slices compared to 16 use less radiation, but that's not the case. Same thing with when we do ultra high resolution mode with photon counting CT, the dosage is not lower. Okay, so that's important to understand. Okay, again, so thin slice, like here. Okay, higher, the more noise. Okay, poor low contrast, but better edge detection. Okay, but you can distinguish the structure better, less, what we call partial volume effect. Okay. Okay, so this is critical for CT, meaning that CT is probably the one non-invasive imaging modality that can achieve isotropic resolution, meaning all the resolution in three axes are the same. So what does that allow you to do? So when the z-axis thickness is the same as the pixel size of the x-y plane, all dimension of voxels is a perfect cube, okay? So you can acquire a data set, allows you to manipulate the structure without distorting it, because in all three dimensions. And if you have a perfect cube, you can add all the number of voxels that you use, you get the volume, because you know the resolution, let's say 0.5, 0.5, 0.5, so this would be 0.01.5, 125 millimeter cubic, and you add everything, you get the volume. That's one way. I believe if you have good image quality, I mean, CT is probably in a static images, probably could get you the most representative volume compared to other imaging modality because of the excellent spatial resolution. Okay, temporal resolution is how the scanner will be able to resolve the fast-moving object, such in this case coronary. We have fellows who've done CAT know that RCA moves a lot, okay? It moves a different type of cardiac cycle, and you really need to freeze the structure, meaning the shutter speed has to be fast enough to freeze the structure in order for you to look at the coronary. And that's why coronary CTA was the last quote-unquote frontier in the organs, the body that was be able to image, not until 1990. Okay. All right, so in image quality, as all the fellow knows, the heart rate determines the image quality, because the heart rate, determine the quiet period of the cardiac cycle. The heart is not moving. That allows you to image, to facilitate freezing the cardiac structure in order for you to image. Okay, so the temporal resolution is determined usually by gantry speed. Okay, the temporal resolution is the gantry rotation time divided by 2, because you don't have to go through the entire patient. You only go through 180 degree. Using mathematical model, you can project what is the profile look like from the other side. Okay, and then this is key. Okay, so if you look at this, the heart rate determines the diastole. Okay, systole is mainly unaffected. But I want you to pay attention, because here we do a lot of systolic imaging, and this is for the advanced imaging fellow. You can look at here. If your heart rate is 60, okay, you get diastasis about 250 milliseconds. If your heart rate is down to 40, you have 500 milliseconds of diastasis. Your heart rate is, over 75, it goes down to about 100. If you look at systole, is heart rate 70, the systole is about 380. But you can only use the last portion of the systole when the heart is isovolumic relaxation time. Okay, so your best bet is always slow down the patient. If your heart rate is less than 60 or 65, the diastasis is going to be always, most of the time, longer than isovolumic relaxation time. Okay? Does it make sense? Good. So that's critical. So 3 words: beta blocker, beta blocker, beta blocker. Okay? Beta blocker is cardiac imager's best friend. Okay? Okay, so, but if the heart rate is slow, is fast, again, anything be above 765, I think is a lot more consistent, the systole, and you can see the image here. It's not going to be a perfect images, but pretty good. Okay, so this is the gantry speed. And that's the reason why we cover it, right? Because with that, I don't think anybody will want to go in there. Okay, so we talk about temporal resolution. So for regular CT, most of the CT scanner, except for the dual source, has a temporal resolution, a gantry time of 250, 220. So this temporal resolution is about 110, 120, okay? Dual source, like what we have, because there's 2 scanners, they don't need to go around 180, they only need to go a little bit over 90. So our temporal resolution is about 60, I would say 65 to 70. It's okay, but nowhere near echo or MRI. And that's why our EF assessment is always going to be lower, because of that subpar temporal resolution compare. Okay, and this is not something we discuss oftentimes, called contrast resolution, right? It's essentially, I mentioned earlier about differentiating different structure. For instance, if this is a patient that has acute coronary syndrome, has chest pain, so this is a CT, a planning scan, before we give contrast. So we know this is part of the, I believe, the sternum, and there's some clips of the lima. You can see some calcium here and there. So we cannot tell what's going on, right? If you give contrast, you see clearly there's something here, yes? Okay? This turned out to be a pseudoaneurysm of lima and anastomosis to the LAD, right? And this is, for our advanced imaging fellow, this is the time resolved mode, meaning that you can see the contrast going through the arterioles and then exit extravasation. Okay, so this is not systolic or diastolic imaging. This is time resolved imaging. Okay. And that allows us to do the plaque analysis. So this contrast, that's why we use contrast, right? We don't ask often why do we use contrast, but now you realize by giving contrast, we're able to differentiate, to look at differentiate the component. So compared to other imaging modality, how do we fare? So CT has the best temporal spatial resolution. The contrast resolution is okay. Temporal resolution is 65, so it's about double of MRI. Obviously, MRI could make it even better as long as it takes a longer time. And angiography spatial resolution is 0.1. The temporal resolution is basically they can get images every 10 milliseconds. So that's obviously the golden grail of coronary CTA. If we can achieve that temporal resolution, we can do real-time CT angiogram. But and if you look at the PET has very good, and SPEC have very good contrast. But the temporal resolution, we don't talk about it very much because you do a lot of adjustment, but you can see the spatial resolution is almost 10 to 20 times worse than CT, for instance, and echo depending on the location and the tissues, but has the best spatial resolution. Right? They can fire ultrasound beam very quickly. All right. Again, you do this every day, but this is critical. ECG gating is how we were able to freeze the heart, okay? And then, so we know we're imaging in diastasis or anasystole when the heart is quiet. Without ECG gating, we'll be acquiring it, blindly. So just to give you an example, this is a patient who has a CTA, non-gated of the pulmonary artery for PE rule out, compared to gated CTA to look at the coronary. Essentially, we're imaging the same structure. You can tell day and night difference in terms of looking at, because this is a mixture of different parts of the cardiac cycle. So you get all this. And, there's always an issue because the patient get a PE rule out, and sure. But we can do this. Only thing they have to do to put an EKG, please, acquire gated, so you can do both triple rule out that we always, we do it routinely here with one single scan. And you might think, oh, this is more complicated, it must be more radiation. If you look at this, actually not. This PE rule out use about 730 DLP, and this CT of the coronary only 170, so even 20% of the radiation used for the chest CTA, non-gated. Okay, this is another example of non-gated. And this is the aorta, which supposedly doesn't move as much. So, this is very hard for you in the middle of the night to decide this patient has dissection or not. When you have image like this, I think it's quite much easier. All right. So we talk about the spatial resolution, temporal resolution, gated, and remember what I told you, that the patient goes through the X-ray and the gantry. There's two ways of patient going through the imaging between an X-ray and the detector. You can move the patient continuously with the gantry rotating the whole time. That will be helical. Or you can move the patient a step at a time. That's called axial imaging or prospective gating. Okay. almost we do helical scan only with the valve patient because we want to know all the information throughout the cardiac cycle. But for coronary, we do almost only prospective, okay? Because we know a priori coronary is quieter during diastasis and the systole. So we prospectively decide which part of the cardiac cycle we're going to image the heart, okay? So that's the main difference. Obviously, if the patient moving continuously and is moving slower than the gantry, you're going to have overlap of data, more radiation compared to prospective. Okay? And that's why we don't do retrospective gating anymore for coronary, because it carries at least 5 to 10 times more radiation. Okay? And that's a concept of pitch. So this is only pertinent to helical mode. Okay? So for prospective gating, the pitch is essentially we call 1 because you move the patient, you rotate, then you move and then rotate and image. Okay, high pitch. So most of the retrospective gating is a low pitch. Okay. So we can determine the moment we want to acquire images and how long the window, meaning that you can acquire, let's say, between 65 to 80%. If the heart rate a little bit variable, and you want some extra security, safety margin. Okay, so this is in principle retrospective gating. The scanner, X-ray source, and detector is on the whole time. Prospective only is on the period that you decide a priority. Okay. Since we have a dual source CT here, we have what we call high pitch mode. So essentially, the table is going to move much faster. Okay, and because we have two detectors, allow us to do that, what we call flash spiral mode. Okay, and that essentially you can image the heart between about 200 to 300 milliseconds and about half a second to a little bit more for chest. Okay, so if you do that with a single source CT, you're going to leave part of the heart without data. But since you have two, that take care of the problem. Okay. So that allows you to do this. This looks like an ordinary study. So for the advanced imaging fellow here, what are the contraindications when someone orders a CT? What situation you tell them no, it's not a good idea? Any volunteer? Say that again? For coronary CTA. Say that again? Okay, so basically if the heart rate is very fast, right? I mean, the image quality usually is not so good, or a lot of calcification. How about following command? You think it's important?
Can't breath hold, unstable.
Okay. So because as I mentioned, since the scanner can acquire the image really fast, we are able to do what we call free breathing. So this patient is a patient, I think Patrick knows about this case, and our imaging fellow. This patient is a patient with dementia that essentially can't follow command, and the neurosurgeon insists to do some pre-op coronary. So the first thing you ask is the patient hyperventilating? So if the patient is breathing 12 to 14 per minute, so each breathing cycle is about 4 4 or 5 seconds, correct? If we can image the heart in 250 milliseconds, if you're lucky, most of the time you have good odds of catching the patient, before they breathe in, breathe out. And this is what happened. This patient is completely free breathing, and we get reasonable image, pretty good image quality. Okay, so this is, you don't want to do this every day, but this scanner has that capacity allow you to do that. Okay. So this is the main difference. You're going to see the table moving really fast. Okay? So if it moves by, how does that 250 millisecond come from? Because if the scanner can move 87 centimeter per second, and the heart is usually 16, right? That's about 1/4. So that's why 1/4 a second. That's why, but it also comes with a price because you have to have very good heart rate. Remember, the heart rate diastasis, I wouldn't do this if the heart rate is over 60, 65, okay? All right, so we'll talk about it, and again, free breathing. Okay, so, but not everybody had dual source CT, but a lot of places, I think most of the places that you guys are gonna practice probably gonna have some sort of white detector, meaning instead of two detector, you're gonna have one single detector, one single source, I apologize, but very, very big detectors, meaning 250. So essentially, the table doesn't have to move, meaning that the detector is so wide that covers the whole heart, right? So every single study will be essentially a prospective gating study, right? Because you don't need to move the patient. The table doesn't have to move. Does it make sense? So there's no helical scan. You can do helical scan if you want to go over 16, but for the heart images, it's a reason why they come out with 256, because you multiply by the detector, give you 16 centimeter, and that's what most of the heart fit, okay? And 2 or 3 major two other manufacturers besides the one we have provide this type of white detector CT. So the advantage is every single heart is imaged exactly the same time, so there's no step artifact, okay? Okay. Okay, something wrong with this, not playing. Okay, there we go. So this is 1B. So this is, this is a narrow detector CT or dual source CT. Patient have to be moved. But you can see here, one single rotation, patient doesn't have to move, and the whole part of the heart is imaged at the same time, so this is very good for perfusion analysis, okay? So, and this is the difference between 64 slide CT and 320 detector CT. There's no stitching artifact. Okay, and you can imagine it will be less radiation as well. Okay, so helical scan with a pitch less than 1, just to recap, retrospective gating, all right? The radiation is going to always be more than prospective gating. The helical with high pitch, essentially higher the pitch, lower the radiation. So in order of radiation, flash high pitch mode will be the lowest radiation, followed by prospective gating, followed by retrospective gating. And we're talking about difference between retrospective gating and a high pitch. Could be an order of 20 or 20 or 25 folds difference of radiation. All right, so this is a concept that I always try to emphasize, because first thing the people are going to ask you, so how many slides do you have in your scanner? All right, it's like, okay. So it could be deceiving. number of detectors is not the same as the number of slices. Our scanner, dual source CT, if you ask a manufacturer, they'll tell you we have actually 384 slices. So how is that possible, right? Actually, what it's telling you is they have 96 slices, 96 detector in each source, okay? So they added 96 plus 96, 190, 92. But electronically, they can create out of each detector 2 slices. So 2 times 192 is 384. So it gets a little bit confusing. And then you have scanner that one manufacturer said we have 512 slices. Well, it's only actually 256 detector. And they do the electronic splitting to create artificially extra slide. So what you need to do, you didn't know really, is what is the Z coverage. That's all the most important thing. Z coverage meaning, for white detector CT, either you cover 16 centimeter, 64 slice cover 4 centimeter. The dual source CT we have cover about 6 centimeter. Okay? So that's a difference. Regular 64 slices, remember, 4 centimeter for 64 slice CT. For dual source third generation, we have two source that cover 6 centimeter, and the wide detector CT can cover 16 centimeter. Okay? That's what you want to know. All right. So we talk about this already. Again, just want to emphasize the difference in image between step artifact, because you do have to stitch. And you can see the contrast is not uniform. So here and here are not images at the same time, versus white detector CT, everything is uniform, okay? Okay, so implication, this is for you to, when you want to, plan or program a scan, you need to know our dual source CT has coverage of 6 centimeter. So in order for you to image the whole heart, you need at least 3 to 4 times, okay, of rotation, and it takes every other beat to do it, so you need to double that. So for prospective gating in our dual source CT, usually it takes about 6 to 8 beats. That's how long it takes to finish the study, okay? Well, you have the helical mode, you can achieve that in 270 milliseconds. So a patient might ask you, how long does the test take, okay? For flash mode, 1/3 of a second. For axial, let's say heart rate 60, you need about 6 to 8 seconds. Retrospective, depends. Could be 8 to 10, depending on the pitch. Okay? So dual source has smaller coverage, therefore prone to step artifact when the heart rate is irregular, but we have better temporal resolution, which that's a reason why scanner was invented, the dual source. The white detector, better coverage, 16, one single rotation. So essentially it takes also, if you think about the gantry time, it's 250. Yeah, if you want to image only one single phase of cardiac cycle, it could be very fast. It could take 250 milliseconds to finish the image and the white detector CT, but the temporal resolution is twice, okay? So it's more uniform, but you get more motion. Does it make sense? Okay? But overall, this compared to 64 slice CT, less radiation, less contrast volume needed, okay? Because it takes less time to image, you need less contrast. All right, last 10 minutes, we're gonna talk about just, all this scanner that we mentioned is called energy integrating, it has what we call energy integrating detectors, okay? What that means is that it's a mishmash of photon with different energy, okay? And the individual pixel of the detector has to have a collimator and a septa to separate for you to know where the signal is coming from, all right? And since the signal is transferred from photon into electric signal and then reconstructed, so you cannot tell what type of energy the signal is coming from, okay? So much more limited. Okay, so this is just kind of illustration showing that this is an electron generated by X-ray source, okay? In order for us to know, differentiate the location of where they come from, we need this, what we call septa, and this is solid state scintillator. It generates, electric signal, X-ray into light, into electrical current, okay? So imagine if we have a different type of detectors that can differentiate a different type of energy, usually a semiconductor crystal. Every single electron could be picked up individually, so we don't need the septa. Therefore, we improve the spatial resolution, and we can tell because we skip the steps of converting. Okay, so you can the energy of the signal coming from X-ray source could be detected and differentiated. So you go from X-ray directly into electrical current. You bypass this photodiode. Same thing with the spec, new spec system, right? So that always gives you better spatial resolution and better contrast. Okay, so and that go into, if you know exactly the energy of the photon, and you can kind of, and it depending what the profile you receive after you go through the body, you can kind of get an idea what kind of composition. So this is a very, a very general statement, but that's the potential for the photon counting CT to do multi-energy imaging for us to do tissue characterization, okay? Which is still not a clinical application, but that's probably the most exciting and interesting portion of this photon counting CT, okay? And all right, so but for now, we're taking advantage of the photon counting CT because of that we don't need to use the septa. Therefore, the spatial resolution is a lot better. So with the dual source, third generation CT, our spatial resolution is about 0.5, 0.6. With the photon counting CT, the minimal spatial resolution we can have is 0.4, but when we apply a high resolution mode, meaning we only focus on small area of the heart, we can achieve spatial resolution of about 0.15, 0.2. So remember that. So it's about half, or we can see twice better the images, and we do that. Now we have enough experience that we do see that all the time. So this is example from the manufacturer. This is our example. This is a patient with about 700 calcium score. You can see this patient had subtotal occlusion, minimal stenosis, and moderate stenosis. before this patient would have been able to scan with an energy integrated detector. Okay, and allows also to see the stent. This is, we can call this Photon, and you can see there's a little bit of low density, low attenuation, so some instant restenosis, and this is a chronic total occlusion of the stent. You can see the stent is completely occluded. Unfortunately, this was a screen capture, but if you look at the aortic valve, the high resolution mode, compared to, pretty, even, so this is 0.2 resolution, this is 0.4 resolution. You can see how you actually can see much better the different component of the aortic valve. Okay, the fibrotic part and the calcium part and the border. Okay, and this is what we talk about the multi-energy spectral imaging. You can create what we call virtual monoenergetic imaging. So if we're interested in looking at the iodine, we can create something close to 40 keV. As you can see, with the integrated, the polyenergetic imaging, there's a little bit of contrast. But if you convert to a virtual monoenergetic, you can see the contrast signal much better. So this whole potential in patients with chronic renal disease that can only receive lower contrast. So this we hadn't explored too much yet, but it's a huge potential. So conclusion obviously is CT is pretty complicated in terms of the acquisition, reconstruction, because it involves a lot of mathematical model, but I try to make it a little bit more clinically oriented so you understand why we do certain things. And we like to provide patient-tailored imaging because not every patient all the patients have different needs. And we're not doing coronary imaging. As you fellows can tell, we image, the indication you get every day, it's always different, right? So you don't want to just prescribe, okay, let's do prospective over the T-wave. Okay, let's do flash mode. You really have to see what's the indication, what's the patient's heart rate. The patient will already hold their breath. The heart rate is regular. If the patient has a lot of calcium, so on and so forth. So, and the most optimal scan mode or parameter is obviously the one that answers the clinical question. And the safest setting to achieve optimal image quality at lowest radiation and contrast. That's what we try. And I think when I read with you guys, I emphasize that because you're here not to learn how to read the study. You also want to prescribe the best image protocol with the lowest radiation and lowest amount of contrast, but still be able to answer the clinical question. Okay. But sometimes you have to compromise. That always. Anyway, that's all I have. Any question? Go ahead.
Yes, one question that comes up a lot of time on general concepts is when we're ordering cardiac CTs, and for example, with the coronaries, are there, oftentimes I know we use contrast quite a bit to kind of help differentiate these morphologically, and I think you alluded to that in your talk. When do we ever not use contrast in those protocols, and are there times when we want to avoid it other than things like ESRD and kidney?
If you want to evaluate coronary lumen, you need contrast. Okay, but again, remember the title is cardiac CT, and the coronary CTA. For current application, people are interested in mostly knowing the stenosis or not, and now more and more the plaque composition. For now, we need to give contrast, right? But if the only thing you're interested in knowing, okay, the patient has calcific plaque, you can do a non-contrast scan. You'll be able to see, as I mentioned, CT is very good without contrast to look for fat, air, water, or calcium. If you want to know that, and the pericardium will be the best case, right? That's why most of the time we do non-contrast or any device, right? If you have a prosthetic mechanical valve, you don't need to give contrast. You want to look at the device per se, but if you want to see the location and the implication, anatomical spatial relationship of that device with the rest of the cardiac tissue, you need to give contrast, right? Because otherwise you just see that prosthetic aortic valve sitting in aortic root. You won't be able to tell if there's any gap between the device and the tissue. Okay. Having said that, I mean, there's always a possibility that technology becomes so good that we were able to differentiate whatever the mechanism is with photon counting, multi-energy imaging. You can differentiate the blood, right? Blood is slightly lower density versus fibrotic tissue, and versus fatty plaque tissue. Okay, that would be, it's a dream, right? You can look at the patient if you can differentiate between blood and soft tissue and fat, you should be able to image easily if you have good resolution. So that could be, if you're interested, that will revolutionize the way we screen coronary disease, right? Okay. I have more question? Thank you.